Nine people. Right, here we go. 3, 2, 1. I'm alive.
Hi everyone, it's David Stockton here with 4:02. So we're just going to give it another minute or two before we start. So I'm not going to sing, dance or tell any jokes, but we are at the moment live and recording. So I'm going to not say any more, just wait a minute or two, then we'll kick off. We can see people joining us at the moment.
Yeah, unfortunately, I appear to have ballsed up the Q&A thing, so if anyone's got any questions, might have to email us afterwards.
Are they emailing them or WhatsApping them to you, Andy?
They could WhatsApp them to the Equine WhatsApp group. Plug.
Yeah.
I'll put the joining details in the meeting chat. There you go.
Or can they put questions in the meeting chat?
Who knows?
Okay. Okay. Well, we'll kick off. So I'd like to say good afternoon and welcome to everybody who's joined us this afternoon, and in particular to Sarah Barker from Dechra, who's talking to us today. Sarah graduated from Liverpool in 2010. She completed an internship at the Animal Health Trust in Orthopaedics and Diagnostic Imaging. She then worked in equine practice in Newmarket and Yorkshire and completed a Cert AVP in Equine Medicine. In January this year, she worked for a period in the vet school in Hong Kong before joining Dechra in July. You'll have already seen Sarah's presentation title is All Testes Great and Small, and she's going to cover castrations in the field, understanding sedation and general anaesthesia, talk about pros and cons of each technique, decision making, and she's going to troubleshoot some of the problems we might encounter. A quick bit of housekeeping. Everybody is muted. The meeting is being recorded. Sarah's presentation will last for about 40-45 minutes, and she'll then take questions. As you've heard, we've got a slight issue with no Q&As up there, but if you could either email them to Andy, WhatsApp them on the Equine WhatsApp group, or try the live chat, we might be able to pick them up from there and present them to Sarah at the end. Final bit, there's no fire alarm practices, so if you hear one over the computer, it's Sarah's. She'll panic, we don't need to anyway, and then she'll collect herself and carry on the presentation. So over to you, Sarah, and look forward to your talk.
Wonderful, thank you very much, David, and thank you very much for introducing me. You've covered the first part of my presentation for me, so that was nice and straightforward. The aim of today's presentation is to cover equine castration, as David mentioned, in ambulatory practice. We're going to look at decision making around castration, protocols for standing sedation, considerations and anaesthetic advice for castration under field anaesthesia, as well as surgical technique and possible complications. And of course, there'll be questions at the end. Feel free to send those through and I'll do my best to answer them. Castration is one of the most common surgical procedures performed in equine practice, and it may be performed for a variety of reasons: to reduce or prevent masculine behaviour in animals unsuitable for breeding, for ease of management, to prevent unwanted matings, and sometimes due to testicular trauma or neoplasia. Owners are often concerned as to what age to castrate their colt. Although castration can be performed at any age, the age of the animal may influence decision making as regards to standing sedation or general anaesthesia, a surgery in the field or in a hospital facility. The goals of castration are as follows: that the procedure is performed safely for the vet, the horse and the handler, that there's complete removal of all required structures, there's appropriate restraint and analgesia, and to minimise post-surgical complications. It may sound simple, but identifying the horse is a crucial part of the preparation for castration. In a racing yard full of bay 2-year-old colts, there's plenty of potential for confusion. I don't know if anyone recognises the horse on the right of the slide. Feel free to send your suggestions into the group. But I'm sure if you have recognised that horse, you'll realise it's Frankel, and no one wants to be responsible for mistakenly castrating the next Frankel. I like to check the horse's microchip, or its markings if it's not chipped, against its passport at the very start of the examination. This is also a good opportunity to get a consent form signed. All horses should be examined prior to castration to determine that both testes are present. Crypt orchid or rig animals are not suitable candidates for castration in the field, and these should be referred to a surgical facility. It's also important that there's no evidence of scrotal herniation. Scrotal herniation occurs when the vaginal ring is large enough to permit entry of abdominal viscera, usually the small intestine, into the vaginal tunic. The terms scrotal hernia and inguinal hernia are often used interchangeably. It's important to make sure that the horse is covered with up-to-date vaccinations for tetanus, and that the size, age and temperament of the animal are all taken into consideration when planning a castration. The location for the surgery, the available assistance and the aftercare facilities should also be incorporated into the decision-making process. Crypt orchids, suspected cases of scrotal herniation, very small ponies, donkeys, mules and other non-routine castrations should all be performed under general anaesthesia and, if possible, under hospital conditions. For castrations performed in the field, then the decision needs to be made as to whether the colt is a candidate for castration under standing sedation or better castrated under field anaesthesia. There are pros and cons to each procedure, as summarised in this table. The advantages of standing castration are that there's a lower cost, less assistance required, it avoids any anaesthetic risk of a general anaesthesia, and it can be a shorter procedure. However, standing castration can be hazardous to the surgeon, difficult to perform on small ponies, and it's not possible in many circumstances to ligate the cord during more challenging surgical conditions. The advantages of field anaesthesia are that you have total analgesia and muscle relaxation, unconsciousness, which is beneficial for surgeon safety, aseptic surgical site preparation, and hopefully more optimal surgical conditions. However, this does come with additional anaesthetic-specific risk, a longer recovery time, and potentially a higher cost to the owner or trainer. As equine practitioners, you'll be sedating horses almost every day of the week for a variety of reasons and procedures. I'm just going to give a quick overview of some considerations when performing castration under standing sedation. Alpha-2 agonists are the mainstay of equine sedation. Xylazine has the shortest duration of action, followed by ditomidine, and finally rimifidine with the longest duration of action. The alpha-2 agonists work via their effect on the alpha-2 receptor. Alpha-2 agonists bind with and intrinsically change the membranes of the alpha-2 adrenoreceptors, preventing further release of the neurotransmitter norepinephrine. Centrally, norepinephrine is necessary for arousal, and if the release of norepinephrine is blocked, the net result is sedation. As you all know, alpha-2 agonists are dose-dependent. All alpha-2 agonists cause side effects, although most, such as the increase in intrauterine pressure, are very unlikely to be problematic during the castration of a healthy colt. It should be noted, however, that the diuretic effects of alpha-2 agonists can be inconvenient during surgery. To perform surgery under standing sedation, the selected alpha-2 agonist should be used in combination with an opioid to potentiate the sedative effects of the alpha-2 agonist, and this may enable a lower dose to be used. Multiple factors may affect your choice of alpha-2 agonist, including your familiarity with the active product and the dose, the duration of effect required, whether it's short or long, the procedure, whether it's pre-medication or sedation for surgery, and the route of administration, which may be affected by the horse's temperament. We'll quickly look at xylazine, which, although licensed for both sedation and pre-medication, is mostly used for sedation for quick procedures such as examining a horse that is a suspected cryptorchid. It has a short duration of action, approximately 15 minutes. Dotomidine is the most popular alpha-2 agonist used in equine practice, and one which you probably use day in, day out. It has a duration of action of 30 to 40 minutes, which works well for many procedures, and also as part of pre-medication prior to field anaesthesia. Last but not least, we have romifidine. Romifidine has the longest duration of action at nearly an hour, and some vets feel that it provides sedation with less ataxia than other agents, which can be beneficial for standing surgery. As well as a choice of alpha-2 agonist, we also have a choice of which opioid to use. There are two equine licensed products available, butorphanol and buprenorphine. Butorphanol is most commonly used in practice. However, studies have shown that buprenorphine provides superior analgesia for castration in ponies under both general anaesthesia and standing sedation, so it might be worth considering this as an option. We're now going to move on to talk about field anaesthesia. There are challenges involved with equine anaesthesia due to their large size, temperament as a prey animal, and their anatomy and physiology, and these must be considered at all stages of general anaesthesia. The anaesthetic procedure is as follows. A pre-anaesthetic evaluation should be performed before pre-medication or sedation. The horse is then induced, anaesthesia maintained, and the horse then recovered. It is essential to place a jugular catheter when performing field anaesthesia to enable consistent and reliable venous access. The catheter can be placed before or after pre-medication, depending on the temperament of the patient involved, but sometimes it is easier to place a catheter once the horse is already sedated. For induction, a large, well-surfaced indoor school that has had all the obstacles removed might be suitable as a location, although consideration should be given to loose particles of surface such as sand, sawdust or wood chip, as these can get into eyes and wounds and also have the potential to be inhaled via the end of an endotracheal tube. Alternatively, a flat grassy field can be appropriate. The area should be free from rocks, holes and obstacles such as farm equipment. Areas close to running water, ditches, close to busy roads or on a slope are not appropriate. It's important to ensure there's enough space for induction to be performed safely for both the horse and the handler. That's not my phone. Everyone needed a bit of light relief, I'm sure. So to go on to induction. In the UK, the induction protocol most commonly involves the use of ketamine plus a benzodiazepine, such as either diazepam or midazolam. There is now an equine licensed midazolam product available following the launch of dormazolam. Guaifenesin can also be incorporated into the induction technique if maintenance via triple drip is to be used. However, this may lead to ataxia during induction of anaesthesia, and it can be problematic in a field situation. Once anaesthesia is induced, the trachea can be intubated and inspired oxygen supplemented. It's recommended that oxygen is provided for any procedure that lasts longer than 20 minutes. This is just a quick visual reminder of the products most commonly used for induction. It's worth mentioning here that ketamine is a Schedule II controlled drug, and so its use must be recorded. Controlled drug registers for this purpose are available free of charge from us at Dechra, so please don't hesitate to let us know if you need one of those. Following induction, a towel is often placed over the horse's eyes to reduce light stimulation. A blindfold or blinkers are not recommended, as these can't be removed quickly. Sometimes the ears might be packed to reduce noise stimulation, and if this is to be done, the packing must be easy to remove. The eyes should have lubrication applied, and the head can be positioned on a towel or a cushion to prevent corneal damage and any possible ulceration. The initial induction will provide anaesthesia for approximately 10 minutes before it must be maintained, and maintenance can be achieved via inhaled gas in a hospital scenario, but with field anaesthesia, it will use TIVA, which is total intravenous anaesthesia, and we're now going to go on to discuss that. There are two main methods of anaesthetic maintenance using TIVA: top-ups or triple drip. This flowchart gives a great summary of how these techniques can be used in practice, and I think it's a really helpful thing to have to refer back to. Following induction with ketamine and a benzodiazepine, there are two commonly used triple drip recipes that can be infused, each containing guaifenesin, an alpha-2 agonist, most commonly xylazine, and ketamine. Ketamine and xylazine can be added to the bottle of Miralax, which is the guaifenesin product, for ease of administration via a drip line attached to a jugular catheter. The duration of infusion should not exceed 90 minutes, as accumulation of guaifenesin can lead to a prolonged and ataxic recovery from anaesthesia. For this reason, it can be advisable not to include the guaifenesin in the induction protocol, but just to use it for the maintenance phase, as this avoids a large accumulated total dose of guaifenesin. Guaifenesin is an irritant if administered perivascularly, so it's very important to make sure that a secure intravenous catheter is placed and that it's been checked before the administration of guaifenesin. It's also important to flush the catheter with a large volume of saline before removal, to ensure that there's no deposition of the drug within the wall of the jugular vein when the catheter is removed, as this could lead to thrombophlebitis. A second method for maintenance is the top-up method. Using the top-up technique, additional ejections of anaesthetic agent are given at set intervals to prolong the effect of the drugs given at induction. This is suitable for short to medium duration procedures up to 40 minutes long. Combinations of ketamine and an alpha-2 adrenoreceptor agonist are usually used. The short onset time of xylazine makes it quite attractive for use in this way, although it's also possible to use ditomidine or imifidine. Usually half to a third of the original doses of ketamine and xylazine are administered after 10 minutes of anaesthesia. Subsequent top-ups can then be given at 10-minute intervals, and these can be a quarter to a third of the original dose, and this again helps to avoid accumulation of drugs. An alternative option can be to administer top-ups when it's felt they are required, and this may be nearer to 15 to 20-minute intervals. However, since ketamine and xylazine both take a few minutes to reach peak effect, confidence in assessing the depth of anaesthesia is required. Waiting until the horse is very light may result in movement, which can be dangerous. I think it's worth noting that nystagmus can continue throughout anaesthesia with ketamine, so that in itself is not a reliable indicator that the horse is waking up. It's advisable to get your assistant to time the duration between doses. If the assistant's not a vet or a registered veterinary nurse, make sure that they're confident how to give the top-up, that they've got the syringes drawn up, labelled and ready, that they can give these via the jugular catheter, and that they understand the need to flush the catheter as well. As a rule of thumb, during the maintenance phase, the total dose of ketamine given should not exceed twice the induction dose of ketamine, as again this may lead to ataxia on recovery. The recovery of horses anaesthetised in the field for castration should be relatively straightforward. There's no need to sedate a horse for recovery from field anaesthesia, but it is important to make sure that the area around the horse is free from obstacles. External stimulation should be kept to a minimum to try and prevent the horse from attempting to stand too soon. If the horse does attempt to stand too soon, it could be ataxic. Most horses will stand within 20 to 40 minutes of the end of field anaesthesia. Although rare during field anaesthesia of healthy animals, there are several side effects of general anaesthesia which we will discuss briefly. The weight of the recumbent horse means that muscles can become squashed, causing painful myopathy, and this can cause issues in recovery and post-operatively. The weight of the horse can also cause nerves to be compressed, leading to neuropathy and potentially permanent damage. Low blood pressure is a side effect of all drugs used in anaesthesia and can cause insufficient perfusion of organs. Finally, the horse's lungs may not fully inflate when recumbent, and this can affect oxygenation, and low blood oxygen in itself can damage tissues. I thought it was worth reviewing some useful tips for performing field anaesthesia to minimise the chance of any side effects or adverse events. A soft surface is desirable, and if in lateral recumbency, the horse should be positioned carefully with the dependent forelimb pulled forwards to relieve pressure on the lower triceps mass and the hind limb separated. The head collar should be removed after induction to avoid damage to the facial nerve from pressure where this runs just below the skin surface, and the eye nearest to the ground should be protected from abrasions with a towel or a cushion. One of the fantastic tools that we can offer at Dechra to help you in the field is our Equine Anaesthesia app. This can be downloaded from the App Store or Google Play. The app enables you to quickly and easily calculate doses for sedation, pre-medication, induction and maintenance, for standing sedation, total intravenous anaesthesia or inhalational anaesthesia. I'm now going to play you a quick demonstration of how the app works. So once the app's opened, you select the procedure that you're going to perform, enter the animal's weight, and then in this instance, we're going to give the horse some ACP before we start. A dose is then calculated as milligrams per kilogram, and then because the concentration of that product is able to be entered as well, it gives a volume in millilitres. I've videoed this procedure all the way through, so the next thing we're going to do is to give the horse a pre-med of ditomidine and butorphanol. And as you can see, when we get to the butorphanol, you can, for any of the products, alter the dose you want to give in milligrams per kilogram, as you can see there for my slightly wobbly videoing. And that then alters the total dose and the volume that you would give to the horse. So now that our horse had a pre-med, he's going to be induced with a benzodiazepine and ketamine. In this instance, we're going to use midazolam and ketamine. And again, it calculates the doses for you and the volume, so you don't have to worry about doing too much mental arithmetic while you're doing everything else you need to do. For this procedure, we're going to have ketamine top-ups for our maintenance. And again, the volume's all calculated there for you. You can then save that procedure to your favourite procedures. So I'm going to save this as castration. And then you can actually create a summary sheet where you give the horse an ID number that corresponds to your practice records. You can put in the horse's name, the age of the horse, the gender. I think I gave this one, yeah, this is going to be a gelding because we've castrated him now. The breed, and it records the weight and the drug doses given. You can then put in the owner's details, and then when you get to the bottom of this form, it gives you the option to email that information to yourself so it can be instantly attached to your clinical notes and you have that all recorded for future use. As well as covering anaesthesia, I thought it was also important to cover analgesia for castration. The BEVA clinical guidelines on equine analgesia state that horses undergoing routine castration should receive intratesticular local anaesthesia irrespective of methods adopted, and horses should receive non-steroidal anti-inflammatory drugs prior to surgery. Butorphanol and buprenorphine should not be considered appropriate for sole analgesia for such procedures, and analgesia should be continued for 3 days following castration. Some analgesia options are shown here: pre-op analgesia, local anaesthesia, and post-op non-steroidal anti-inflammatory drugs. As a guideline for local anaesthetic volume, most horses require 15 to 20 mL per testy, with some also administered subcutaneously. And as the title of the talk goes, this can be altered appropriately for testes great or small. A 3 to 5 day duration of non-steroidal anti-inflammatory drugs is usually appropriate for post-op analgesia. It's important to ensure compliance with post-op analgesia. In fact, I think this is probably one of the most important considerations for post-op care. Inadequate analgesia may result in the horse being unwilling to move and therefore at greater risk of post-op swelling at the castrate site and potential complications. Equipalazone comes as both a paste and a powder formulation, which may help to give different options for easy administration. When I leave to do a castrate and arrive at the yard, I like to have a mental checklist of the equipment I'll need. Everybody has their individual preferences, but it's always important to carry spare equipment in the unlikely event it might be required. I like to make sure that if doing a GA, I have a padded head collar and a lunge line. In all cases, a microchip scanner and the horse's passport in order to check its ID. Catheters, a sedative, analgesic drug, anaesthetic drugs and antibiotic drugs, plus spare of all of these. Needles and syringes. A tail bandage, which I think is really helpful to stop the horse from flicking at you during standing sedation. Water, hibby scrub and cotton wool. Gloves, both sterile and non-sterile gloves. Scalpel blades, which for some reason is the thing I always seem to leave in the car and have to go back for. Swabs, emasculators and a watch or a stopwatch. I quite often find it helpful to leave the assistant holding the horse in charge of the stopwatch, as it gives them something to do and helps to sort of engage them with the process so they don't just stand there thinking about what they're going to have for dinner that night. I also like to run through my preparations in exactly the same order each time. The first thing I do is to check the identity of the horse and, unless I'm able to weigh it, estimate the weight. Sedate the horse and then place an IV catheter if I'm using it. Ensure that both testes are present and that there's no evidence of any scrotal herniation. Administer any pre-op analgesia or antibiotics if appropriate. Apply a tail bandage. And then at that point, I would induce anaesthesia if I was performing the surgery under GA. Position the horse, as we described earlier. Clean and prepare the surgical site. And prepare the surgical equipment and apply sterile gloves. Positioning the horse is obviously extremely important for a horse that's recumbent for a GA, but even for standing sedation, I do find it quite helpful to try and get the horse to stand with its left hind leg slightly behind its right, so there's a little bit more access for surgery. It just makes life easier. The use of antibiotics to prevent post-op infection with castration is debatable, and it should be based on your own evaluation of each individual case. The presence of adverse weather conditions, such as hot weather with associated flies, or cold, wet weather that leads to inadequate turnout, muddy areas, or an unhygienic surgical field, may influence your decision for antibiotics or not. TMPS is specifically indicated as a broad-spectrum first-line antibiotic in BEVA guidelines for antimicrobial use. The bioavailability of TMPS is reduced in the presence of food, so this may be a good reason to use paste to increase bioavailability and to ensure compliance. We're now going to go on to the surgical technique itself. The Reimer, Serra, and modified White's emasculators are those that are most commonly used. Although they all differ slightly, the choice of emasculator is often down to surgeon preference, or really what's available in your practice. The Reimer emasculator crushes the spermatic cord, and a blade operated on a separate handle cuts the cord distally. The improved White's and Serra emasculators simultaneously crush and cut the spermatic tissue at the same time. Castration can be described as closed, semi-closed, or open, depending on the surgical technique used and whether that technique involves the opening of the parietal tunic. We're now going to run through these different techniques. In closed castration, the incision is made through the scrotal skin, the tunica dartos, and the scrotal fascia until the parietal tunic is encountered. The testes is grasped and separated from the scrotal fascia. The emasculators are then applied to the entire spermatic cord, and during this procedure, the parietal tunic is not opened. Semi-closed castration is similar to the closed technique. However, after the parietal tunic and cremaster muscle are exposed, a 2 to 3 centimetre incision is made in the parietal tunic, just proximal to the testes. The contents of the parietal tunic can then be inspected to ensure there's no evidence of herniated intestine. Emasculators are then applied to the entire spermatic cord, including the parietal tunic, proximal to the testes. In open castration, the parietal tunic of the testes is incised. The testes, epididymis, and distal portion of the spermatic cord are completely freed from the parietal tunic, exteriorized, and removed using the emasculators. This is the most commonly used technique for castration in the field, and so we're now going to walk through each step of an open castration. Having completed the preparations we described earlier and put on your surgical gloves, make sure your kit, so your swabs, scalpel blade, emasculators, etc., is within easy reach. I find it quite helpful to have these on a tray and then I can slide them towards me if I need to. If castrating the horse under standing sedation, I stand to the left side of the horse and approach the right, so the offside testes first. If the horse is recumbent, then approach the lower testes first. This is just to avoid any blood in your surgical field obscuring your vision. Firmly grasp the testes to push it down into the scrotum, and then incise boldly along the median rafe of the scrotum through the tunica dartos and the parietal tunic. This can be quite a bold incision, and the incision should be of a reasonable size, so 10 centimetres long approximately in a thoroughbred. These incisions also need to be made as ventrally as possible to encourage good scrotal drainage. Poor drainage will encourage swelling and also increase the risk of infection. I should just say that these diagrams are taken from Peter Green's paper from In Practice, and there's some really nice illustrations there if you wanted to refer back to them. Following the incision, the testicle should then drop to be exteriorized. Swabs can be used to ensure the parietal tunic is not covering the testes, and a window is then made in the mesorchium and the neovascular spermatic cord emasculated. The jaws of the emasculators should be applied at right angle to the spermatic cord to ensure crushing of the spermatic blood vessels, and it should remain in place for at least 2 minutes. There's variable reports as to how long emasculators are left in place by different surgeons, and I have read that some surgeons leave it in place for 1 minute for every year of the horse's age. I would say that whatever time you leave it for, as long as it's greater than 2 minutes, it's really important to have that time being recorded and timed by somebody, because it's very easy to underestimate the length of time that they should be on when you're timing it in your head and being distracted by people asking you questions and talking to you. I probably should have mentioned this sooner because I think it's the thing that everybody remembers from vet school, but as you can see in the diagram on the right of the slide, the emasculators should be placed on the testes nut to nut, so your wing nut is always pointing down towards the testicle. Ideally, the spermatic cord should be isolated and emasculated as proximally as possible, because this helps to prevent any post-op protrusion of the severed cord through the scrotal incision, which is the kind of thing that owners like to ring you about just as you've got home. Hemorrhage is not considered to be significant as long as you can count the drops of blood, and this usually decreases and then ceases within a few minutes of surgery. The final stage of the open castration technique is to emasculate the musculofibrous cord. The scrotal incisions are left open to heal by secondary intention. Because of the high risk of wound contamination, they should never be sutured in standing castrations. I also just thought it was worth mentioning that you need to consider removing these testes from the site of surgery, not to leave them in the field or in the horse's bed in the stable. They should be at least removed and disposed of as clinical waste. And I say that having been the vet where somebody's dog ate a testicle, and I wasn't the most popular person, although the dog was absolutely fine, luckily. In a hospital scenario, then transfixing ligatures may be placed. This is usually only recommended to be done in a sterile operating environment, so it's rarely advisable to do in the field, but I felt we should at least mention it. The presence of foreign material at the castration site has been reported to increase the risk of post-operative infection. Donkeys typically have larger vessels in the spermatic cord, and therefore it's recommended to place ligatures in these animals, and therefore they should be referred ideally to a surgical facility. Post-operative care should not be neglected, and it can really influence the risk of post-operative complications. Once the horse is recovered from sedation or anaesthesia, ensure that there's clean bedding in the horse's stable, which helps to allow better monitoring of how much bleeding there might have occurred. Make sure you leave any analgesia or antibiotics with really clear instructions. I think this is a really important part of the post-op care. I usually recommend box rest for 24 hours, followed by controlled walking exercise or turnouts, which slightly depends on the facilities available and the temperament of the horse. Also remind the owner not to leave a tail bandage on overnight. If you can remove it before you leave, or ask them to remove it later on that day. And again, if it's hot or sunny weather, fly repellent can be really helpful just to try and deter any flies from landing on the castrate site. So just not obviously on the site itself, but around the horse's belly and maybe on the front of its stifles, that kind of area. Although castration is one of the most commonly performed equine surgeries, it does still carry a risk of complications, and I think it's important to discuss these potential complications with the owners prior to surgery. Often they do think of it as something very routine, and they may not be aware of some of the possible outcomes should things not go to plan. However, having said that, to reassure you and them, the overall complication rate of routine castrations in a study from 2013 of 324 horses, there was only a 10.2% complication rate and only 0.3% mortality rate. So that is quite a reassuring statistic, I think. The most commonly encountered complications include excessive post-op wound swelling, post-op hemorrhage, incisional infection, and eventration or evisceration. Less common complications include anaesthetic incidents, iatrogenic penile trauma, penile paralysis, serous cord, hydrocele formation, or peritonitis. Bleeding scrotal vessels should be clamped and ligated, but if the hemorrhage is coming from the spermatic vessels, a long hemostatic forceps can be used to grasp the end of the transected cord. The forceps should remain in place for 12 to 24 hours until the hemorrhage has ceased. I do remember doing this for the first time in a horse that I felt was bleeding more than I was comfortable with, and I was really worried about how the horse would tolerate the forceps, and he didn't bat an eyelid. They were quite comfortably stayed in place for 24 hours. We removed them, and there was no further hemorrhage. So I think, having done that myself, it's actually a much easier technique than perhaps it sounds. If the source of hemorrhage can't be located and controlled in a standing horse, then at that point exploration under general anaesthesia is indicated. In those cases, severe blood loss may need volume replacement with intravenous fluids or whole blood, but that is a worst case scenario. I think this is a good point just to quickly review some key messages from today's talk. It's important to undertake a full evaluation before deciding on the most appropriate technique for castration, whether that be standing sedation, a GA in the field, or even referring to a hospital facility. Always make sure you do a full clinical examination pre-op in every horse, including identifying the horse and checking for scrotal herniation or whether it's a rig. Always place a catheter for field anaesthesia, and also to make sure your assistant is well prepared and or trained. I think it's helpful to know in advance who might be there, whether it's just the owner or owner's staff or another pair of hands, and then to be able to take someone with you if you're not happy with the assistance available to you. Ensure that you have appropriate analgesia considered at all stages of the castration procedure. And also make sure that you prepare the owner or trainer before surgery about the risk of possible complications and the importance of the post-operative management and care of the horse. Finally, we do have support tools available at Dechra to help you in practice. I think I've mentioned most of these through the talk so far, but they include the Controlled Drug Register, the Anaesthesia app, and also the Dechra Academy, where if you log on, you can find various useful webinars on different topics that can be of help. I also should mention that our teams are all still available for phone calls and online video calls. So if we can offer any help or team training, then please don't hesitate to get in touch. We are all here waiting to give you a hand if needed. And so finally, that brings me to my last slide and ask if anyone's got any questions.
Brilliant, brilliant.
Thank you very much, Sarah.
You're welcome. Now, am I meant to be able to find some questions somewhere now, or is that is that too complicated for me?
Hopefully, I've been collecting them.
Oh dear. Okay.
I've got some questions, but I can hear myself talking back through the speaker, which is slightly disconcerting. So hopefully nobody else can hear that. So the first question is, what's your preferred method for calculating the weight of the horse in the field? Estimate, wayband, or the good old girth squared times body length equation?
Well, I did a little bit of research on this a while ago, actually, for practice standards, and apparently the calculation is the most accurate. But if I'm really honest, in the field, I tend to go with my estimate by eye, and I hesitate to think how accurate I am, but I feel like I've been quite lucky so far. So I think it depends on your confidence. I am probably lucky that the majority of the horses that I castrate in practice are thoroughbreds of a fairly predictable size and weight, and that probably makes my life a bit easier. But if unsure, it's definitely you can definitely use the equation, and it is meant to be very accurate.
Thank you very much. So the next one, do you give prophylactic tetanus antitox?
Personally, I don't, unless it's been requested and discussed with the owner or there's a particularly high risk, as long as the horse is up to date with tetanus vaccinations. If not, then it is a discussion to be had with the owner that you give a tetanus vaccine and the tetanus antitoxin as a prophylactic cover. I do know people who routinely give the tetanus antitoxin as prophylactic cover, and I think it is an element of personal choice and cost as well, because it does add considerably to the cost to the owner. So probably that's a little bit of a hedging my bets answer there, but I think it needs to be discussed.
That's great, thank you. I've got another comment here. 30 years castrating and always leave emasculators on for 3 minutes on each side, regardless of the horses or my age. Never had a bleed. Probably luck. So that's a comment there. And the next question and final question is, whenever I do an open castration, I always tear off the ligament from the testicle, which allows better exposure before I use the emasculators. What are your thoughts on this?
Yeah, I think if you've got the swabs in your hand and you can sort of strip the testicle in order to get better exteriorization, I think that's really helpful. I think sometimes it depends for me as to how relaxed the horse is. Some horses seem to exteriorize their testicles quite easily and you don't feel like you're having a fight, and others, for whatever reason, seem to hang on to them a bit more. So I think, yeah, definitely a possible technique and something that I've done myself as well. And I quite like the comment about the age of the horse or the surgeon doesn't affect the length of time they leave the emasculators on. I tend to go for 3 to 4 minutes myself, but I just quite liked this this fact that I'd read about certain surgeons using the age of the horse as a guideline. You wouldn't want to do an old horse for 15 minutes, though, I think.
I was just thinking the same thing, Sarah, because before I finished in practice, we used to do a lot of work for a rescue centre, and yeah, some of those were in early double figures.
Yeah, I'm definitely not recommending that. Yeah, I just thought it was an interesting idea.
Yeah. That's great. So no more questions, Andy?
No more questions. So
okay.
Wrap up.
If anybody does have any questions, particularly about anything we've talked about in this, they're welcome to get in touch. They can just pick up the phone or drop us an email, and we're always here to answer any questions.
Thank you ever so much, Sarah. So yeah, we'll wrap up. There was a great presentation, really good, and a good cover off. So thank you very much for that. I'd also like to just thank Dechra for obviously supporting this webinar, and thank everyone for who turned up and attended as a part of the audience. So I suppose at that point, Andy, we'll close the recording, say goodnight to everyone, and the recording will be available to anyone who wasn't able to come along. So if any of your colleagues were intending to be here and haven't made it, then we'll circulate that round to everyone.
Thank you very much.
Thank you.